Just ahead on this edition of Being Well, oncologist Abdur Shakir from the Sarah Bush Lincoln Regional Cancer Center will be here to talk to us about lymphoma. We'll learn more about the two primary types, Hodgkin's and non-Hodgkin's, and how they are diagnosed. Dr. Shakir will run down the list of symptoms and will tell us what someone should do if they think they may be at risk. That's all coming up next on this edition of Being Well, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. Welcome back to Being Well, and a familiar face to the show has returned. Dr. Abdur Shakir from Sarah Bush Lincoln, our favorite oncologist, has come back to talk about lymphoma. Thank you for joining us.
Thank you for having me.
We haven't seen you in a while,
yes,
so we actually changed sets since the last time he was here.
Yes.
But we enjoy having you come on because you do a great job of explaining these complicated things in ways that we can all understand. So we've chosen lymphoma today, and it deals with the lymphatic system, which I think you need to set that up because it's kind of a complicated thing for people to understand.
Sure. So the lymphatic system is a part of a larger system called a circulatory system. Very similar to arteries and veins, this lymphatic system is a network of vessels that traverse throughout the whole body, very similar to a complex highway system. The lymphatic system contains fluid called lymph. Arteries contain fluid called blood. The lymphatic system contains this lymph. Lymph comes from the Latin word meaning water. So one of the functions of the lymphatic system is to regulate our water balance in the body. And the second part of the lymphatic system is that this lymph contains something called lymphocytes. Lymphocytes are a type of white blood cell that's made in the bone marrow factory, along with other blood cells, red blood cells and platelets. These lymphocytes travel throughout the lymph glands and the lymphatic system and go and congregate in lymph nodes. So lymph nodes are intervals throughout this lymphatic system, kind of like a rest area in the highway system. So people think of lymph nodes like in the neck, under the armpits, in the groin, but the spleen is a lymph node, the thymus gland is a lymph node, the tonsils are lymph nodes, they're all lymph nodes in our body. The lymphocytes play a vital role in fighting off infections, viruses, bacteria, and funguses. So the second main function of the lymphatic system is to act kind of like the Secretary of Defense. If an infection happens, these lymphocytes and lymph nodes act. Now, when a person has a tumor of the lymphocyte, a tumor of the lymphatic system, a tumor of the lymph node, we use the term lymphoma.
Okay, so I know from looking at it, research, there's two basic types, but within that, it gets a little more complicated. But talk about the two different types of lymphoma.
So the two standard types that most oncologists will tell you is you either have Hodgkin's lymphoma or non-Hodgkin's lymphoma. Hodgkin's lymphoma is the less common variant, roughly about 9,000 cases per year. It was famously coined after Dr. Thomas Hodgkins in England in 1832, who was a gentleman to actually introduce the stethoscope to physicians.
Okay, well there's our fact for the day.
There you go. And he was actually able to figure out that these lymph glands look different than tuberculosis, and he came up with the term Hodgkin's lymphoma. Now, Hodgkin's lymphoma has something called a bimodal variation. What that means is it occurs in two separate age groups, usually 15 to 30 or 60 to 70. And there are four different types of Hodgkin's lymphoma: nodular sclerosis, lymphocyte predominant, lymphocyte depleted, and mixed cellularity. Conversely, when we talk about non-Hodgkin's lymphoma, much more common. Roughly 85% of all lymphomas are non-Hodgkin's lymphoma. There are much more common, in fact, that 70 to 75,000 cases will be diagnosed this year in North America. Wide variety of age groups from 1 to 99 can actually really occur. There are as many types of non-Hodgkin's lymphoma as there are Republican candidates for president. That's how many wide variety of types. How I really group non-Hodgkin's, and this is important, every oncologist groups them a little bit differently, but how I do it is in different grades. A person may have a low-grade non-Hodgkin's lymphoma, a middle-grade non-Hodgkin's lymphoma, or a high-grade non-Hodgkin's lymphoma. And there's a reason why we classify those into 3 different grades is because treatment's different for all different 3. Low-grade lymphomas are really slow-moving that can actually last for years without any treatment. High-grade lymphomas can grow within a matter of weeks to days in people and need treatment roughly within a week's time. And intermediate grade, you got to make a decision with your cancer physician.
So is the cancer in the lymph node, is it a tumor, or is it cancer cells in that lymph fluid?
So as you remember, that lymphatic system is this highway. And you may have a tumor in the lymph node that you can visibly see, but there's likely cancer cells that are traversing throughout that lymphatic system too as well. So you may be able to visually see a lymph node, yes, but I'm betting that there's probably cancer cells in many different locations as well too.
So since that moves around, can those cancer cells stop and deposit in other places of the body and cause other types of cancer?
Typically no. They typically don't cause other types of cancer, but they may deposit into a different lymph node. So if you had a lymph node in your neck, it may deposit down to a lymph node under your armpit or into your groin because those lymph nodes continue to travel, or that lymphatic system continues to travel.
Okay. How is someone ever going to know that they have it? What are some of the early symptoms?
Sure. So there's a sign and then there's symptoms. The first sign of lymphoma is a person usually comes into their family care doctor's office stating that I have swollen, non-tender lymph nodes in my neck that's been growing, and the family physician has ruled out infection, has ruled out autoimmune diseases, and then starts to think of, boy, could this be a cancer like lymphoma? Then there's 4 symptoms, and the classic 4 symptoms that oncologists tell patients called B symptoms. Fever, fatigue, weight loss, and night sweats. With fevers, what happens with patients is they went to their family doctor, they've ruled out an infection, they've ruled out autoimmune diseases, they've had cultures and urine tests done, and they can't figure out the reason why. And then they come to an oncologist and say, boy, I've had these fevers, and now I've had this lymph node that's swollen. We start putting 2 to 2 together. Fatigue is a tough one because we're all tired at the end of the day. At the end of the day of work, it's hard to say fatigue, but if it's outside the normal, if you say, boy, I'm working every day and now I'm really feeling tired just waking up in the morning, we start to think about those things. Night sweats, what happens to a patient is, in the middle of the night, they got to get up, change their shirt. They say, I'm drenched and my shirt is all wet. I don't know the reason why. And that happens repetitively. It can happen for other reasons, hormonal reasons, but it can happen with lymphoma as well. With weight loss, there's roughly about a 10 to 15% loss of body weight, unintentional loss of weight, and that can sometimes alarm patients to trigger lymphoma.
So if you have swelling, the lymph nodes that you can feel are the neck. Where else did you say? Under the armpits. And in the groin area too as well, that you can typically feel. Because a lot of times when you get that sore throat, that's what swells up first. And
correct. So part of an infection, what happens is those lymph glands start to work. They say, I got to fight off this infection, so they may initially swell before they go back down.
So is this like some of our other cancers, like breast cancer, is this hereditary or genetic in nature?
No, there's not a genetic mutation. There's nothing that's from the mother to the daughter or from the father to the son that goes on. So when people think of family lymphomas, it's not really related to mutations that are transferred. It's likely related to the environment.
Okay, so let's get into, are there some risk factors or things that cause it?
This is probably the most common question when a person comes in to sit in front of me to have this discussion of lymphoma. That's the most common question is, how did I get it? What are the risk factors that do it? Usually I break it down into 6. The first is infection and viruses. People don't think about that. But there's a certain infection called H. pylori, which happens in the stomach, which is notorious to cause a certain lymphoma called a gastric malt lymphoma. When a person is treated for this bacteria, actually that lymphoma can go away in certain scenarios. There's also other viruses, HIV, hepatitis C, Epstein-Barr virus, have been all associated with lymphoma. The second cause is environment. There has been clear distinctions of patients who've been exposed to insecticides, pesticides, herbicides, and especially in farming communities. There's a higher incidence of lymphoma, particularly in the Midwest, because there's a lot of farming that's here. So part of that environment is when people think that, hey, my mother had lymphoma, I might have got it from her because she had lymphoma. That's not really the case. What's really the case is the environment that they're all living in.
And it could be if you grew up on a farm, maybe you drank from the same well, it was in your water
or
supply.
persons is spraying the exact same pesticide to the whole family in the same area. The third reason is autoimmune diseases. Rheumatoid arthritis, lupus, mixed connective tissue diseases all regulate the immune system or dysregulate the immune system that can cause lymphomas. The fourth is patients that are on medicines to suppress the immune system. You say, what are those patients? Those patients are patients that have had a liver transplant or a kidney transplant, or patients that actually have had chemotherapy in the past can actually be a risk factor for developing lymphoma too as well. Patients that have been exposed to radiation treatments, or for example, Chernobyl or Hiroshima, those patients are at risk for developing lymphoma. The fifth reason is diet. People don't think about diet, but low intake of vegetables and high intake of red meat. The National Cancer Institute have been doing studies on this and have found that there's a higher correlation of lymphomas in patients that are not eating enough vegetables and having a higher intake of red meat. And they're trying to figure out that correlation. And the last is idiopathic, which means we don't know.
just no unknown.
They just don't have a good reason why.
All of the cancers that are out there, where does this one rank in terms of, I'm not going to put you on the spot and say how many people will get it, but you know, we've got lung cancer, breast cancer. Where does the lymphomas fit?
It's the fourth most common type of cancer that we see. But like you said, lung cancer, breast cancer, prostate cancer, those are things we commonly think of. Lymphoma in the Midwest is a type of tumor that we commonly think of as an issue for patients.
So as if the person goes to their primary care physician, they're maybe turned over to an oncologist such as you, then what are your next steps in diagnosis?
So as an oncologist, there's two different ways to diagnose this type of disease. The first is a biopsy, and it depends on where the lymph node is located, where we take a sample of a lymph node. And the second is actually removal of a lymph node. We actually take out the whole lymph node and remove it. As an oncologist, we actually prefer removal of the whole lymph node. And this sometimes can frustrate a family doctor, a patient, because numerous procedures are happening. The reason why we prefer to remove a lymph node is, imagine the lymph node like a house with many different rooms. And if you just sampled one room, that room might have looked clean. And you'd say, okay, this is a low-grade lymphoma because the room looks clean there. But if you actually remove the whole lymph node, you're able to assess every single room in that lymph node. And then you're saying, okay, that room is clean, but the rest of the room is really dirty. And that's a high-grade lymphoma. So treatment decisions are really based upon that removal of the lymph node. Part of also the diagnosis is we do CAT scans of the whole body, we do something called a PET scan, and we also do a bone marrow biopsy to see what stage a person is.
So is the removal of the lymph node pretty common?
Ideally, yes, but it all depends on where the lymph node is located. If it's located in the neck, it's easy to remove. If it's located under the armpit, easy to remove. Located in the groin, easy to remove. But if it's in the middle of the chest somewhere or in the abdomen somewhere, typically then we're stuck with doing a biopsy to get a sample, because removing that lymph node requires a major surgical operation sometimes.
So once you've kind of gone through that and you see what kind of lymphoma it is, are people treated with chemo, radiation? How do you determine that treatment?
So the treatment plan is really broken into 4 different sections, and there's a lot of caveats, but how I break it down is observation, chemotherapy, radiation, or bone marrow transplantation. Now, with observation, it's really important. Some people may hear that and say, oh, I don't have to get treatment. There's a very select group of lymphomas that actually do not need treatment, that can be safely watched. So the majority of the second opinions that I get is, should I get treated or should I not get treated? And that's really where your expertise of your oncologist will come in and say, I can safely watch you, or no, we better start treatment quite soon. The second is chemotherapy. Now, chemotherapy differs in Hodgkin's and non-Hodgkin's lymphoma. With Hodgkin's lymphoma, there's a classic chemotherapy cocktail called ABVD. With non-Hodgkin's lymphoma, because there's such a large variety, each different type of lymphoma has a different cocktail, and that's where your oncologist will come into play and say, aha, we're going to tailor this chemotherapy towards your type of lymphoma. The third is radiation. Depending on the type of lymphoma, how large the lymphoma is, radiation may come into play or may not come into play. And the last part is bone marrow transplantation or stem cell transplantation. Depending on how aggressive the person's lymphoma is, stem cell transplantation may immediately be done after chemotherapy, or waiting for a person to reoccur and then do a bone marrow or stem cell transplantation.
I'm sure it's going to be hard to answer this next question because the range of what people have is so very. How long is that treatment plan usually last?
So-
Typical.
So for example, if we're talking about a high-grade lymphoma, you're roughly thinking about 5 to 6 months worth of chemotherapy, and if they needed a bone marrow transplant, roughly 30 days in a hospital.
Okay, wow.
Yeah.
So for your patients that you've treated with this, can they do this? Are they bedridden, or can they kind of go about their regular life?
So every person is slightly different, as you know. And some people are able to work full-time and able to do their full-time job, and some people the chemotherapy really wipes out their function. And then we have to battle, keeping their cancer under control and also giving them their quality of life too as well.
Okay, so let's talk about, survival rate. How does this rank in terms of our other cancers?
So Hodgkin's and non-Hodgkin's are different. If we look at Hodgkin's lymphoma, we base that on stage. So stage 1 Hodgkin's, 90% of people are cured over a 5-year period of time. Stage 2, 85% are cured over 5 years. Stage 3, 75% are cured over 5 years. And stage 4, 65% are cured over 5 years. In non-Hodgkin's, we really break it into 3 different types: low risk, intermediate risk, and that high risk. Low risk non-Hodgkin's, 90% are doing great after 5 years. Intermediate risk, 70% are doing great after 5 years. And high risk, about 40 to 50% are doing great after 5 years.
So this has better survival rates than some of our other cancers
Yes,
out there,
yes. No,
definitely.
in general, these lymphomas are curable. There are certain types of lymphomas that are not, but in general, these lymphomas are curable, and that's why it's really important to devise an appropriate treatment plan for these patients.
Early detection, just like any cancer.
Yes, as you can see with the stages, can make a difference.
All right. So are there any other people, someone had asked this question, are people who have lymphedema, which lymphedema is just swelling, are those people at higher risk for getting lymphoma?
No.
Okay.
So a lymphedema is a localized obstruction to a vessel in the lymphatic system. Lymphedema typically occurs as a consequence of lymphoma.
Okay.
Or as a consequence of an infection, or as a consequence of surgery. For example, in breast cancer patients who've had their breast tumor removed and their lymph nodes removed, it could be as a consequence of that, but it's not a cause of lymphoma, no.
All right. Let's talk about some of the new things on the horizon, because I know you're always looking for new things and trying new things. So what's new on the horizon for people with lymphoma?
So when we think about the therapies, the first is chemotherapy. That's really been a backbone of how we treat lymphomas. There are a new set of class of drugs called monoclonal antibodies. So there's shotgun approaches to chemotherapy, and there's something called sniper rifle approaches to chemotherapy. And these monoclonal antibodies are sniper rifle approaches. There's a famous monoclonal antibody called rituximab, which has historically been used in non-Hodgkin's lymphoma. Now, the newest clinical trials are trying to develop multiple different sniper rifles, or these antibodies. So hopefully over the next 2 to 3 years of time, we're going to see these new monoclonal antibodies develop. The second is with bone marrow transplant. Bone marrow transplant, there's 2 separate types. One is called autologous, where you get your own stem cells transplanted back to you, and the second is called allogeneic, where you're getting transplant from somebody else, either a related person or an unrelated person. With autologous, the risk right now is when we transplant the cells back to a patient, we may be transplanting some cancer cells back. So what we're trying to do now is sift through those cells to say which has the cancer and don't transplant them, and what are the normal cells and transplant the patients. With allogeneic, there's a risk of a side effect called graft versus host disease. And that's a major side effect that we deal with allogeneic transplants. We're trying to alleviate that risk because that becomes a quality of life issue for patients. Lastly, vaccines. People have, you probably heard in the news, 60 Minutes and all this stuff of talking about vaccines for brain tumors, but actually vaccines have been looked at specifically for lymphoma. And there's some late phase 3 clinical trials at the moment that are ongoing looking at how do we rev up our own immune system to fight against the lymphoma.
I wanted to ask, we do hear about bone marrow transplants. What is that really doing for people with cancer?
So it's specifically used in a couple different types of cancers. Lymphomas is one, leukemias is another one, and another disorder called multiple myeloma. They're all bone marrow type of cancers. Now, what bone marrow transplants do, depending on what type of disease that you have, it's basically like a farming community where you have all these crops that are up, like your own blood cells. You wipe out all those crops and you really plant in new seeds, like these new stem cells, and hopefully those new stem cells grow normally.
Okay.
So that's that's really what a transplant is. And the goal of the transplants in these patients, a majority of the patients, is how best do we cure. In certain scenarios, it's not used for that. It's used to delay the progression of the cancer. But for example, in lymphoma, is how best do we cure it with a transplant. In leukemia, how best do we cure it with a transplant.
Okay. We've got just a few minutes left, and I want to save my last question for the very, very end. But before we do, are there any other things that you wanted to talk to us about lymphoma?
Yes. So I think it's really important when a patient comes to see their oncologist. There's a team-based approach to treating their lymphoma. For example, how we do it at the Sarah Bush Lincoln Regional Cancer Center is we have an oncologist who's kind of the ringleader to decide what goes on. And then there's a radiation oncologist who determines who gets radiation. There's a surgeon who helps diagnose. There's a family doctor who juggles their other medical problems while a person's getting therapy. There's a pathologist who plays a vital role in coming up with these complex diagnoses. There are great chemotherapy nurses that are part of the team to help make the situation of chemotherapy comfortable. But also what we do is we work with specifically lymphoma experts at the University of Illinois at Chicago to say, hey, I have this complex case. How best do we treat this person? And I think when a person has a lymphoma, they should at least have that team standing behind them to say, what's the best treatment for me?
When people are diagnosed with cancer, it's very, very overwhelming. What sort of recommendations do you have as an oncologist to help people sort of digest all that information so they can get it right in their own head what's going on?
Sure. The first visit is the most difficult, and roughly about 30 to 40% is retained. So what I usually do for a patient is the first visit is the first shock of they hear is they have lymphoma or they have a cancer, and the rest after you tell them is just not absorbed. So we usually do an initial visit, and I say come back in a week or come back in 2 days, and we're going to go over it again.
Okay.
Because that first initial shock of hearing the lymphoma, they usually forget of everything that I told them right after that. So the next couple days, we go over the whole process again, and we usually ask family members to come in, have a person that's a recording secretary to ask questions, or go home, write a list of 15 to 20 different questions. So when you come in, all those difficult questions that you didn't know how to ask then are then being written down on a piece of paper and being checked off and asked.
All right, because it's a lot and new terminology and all sorts of things.
Yes.
As we wrap up here, I want to talk about cancer in our region here in Coles County area. What are you kind of seeing? What are the majority of your patients coming in with, and where are we at with cancer in our area?
So the majority type of cancers that we see in Coles County is breast cancer, lung cancer, and prostate cancer, which is historically the most common. So we really follow the other counties as well too. Specifically in Coles County, lymphoma is one of those tumors that we do see on a higher incidence than other areas simply because of the farming community.
Right.
We're hoping specifically for breast cancer and lung cancer, we can make those changes with early mammograms and sometimes early CAT scans. With lymphoma, it's hard to change the environment.
Yeah, we are in a
farming community, so it's hard to change that environment. But it's important that a patient at least explains to their physician the symptoms that are going on. In a majority of the scenarios, patients aren't open to their symptoms. So it's really important that they go to their family physician and say, hey, I'm losing weight, or hey, I'm having these night sweats. So it's important that patients have this open relationship with their physician.
And thinking about, this is not, what is your normal?
Yes.
And it is not normal to be profusely sweating, unless you're menopausal women, which I know there's many out there like, I have that all the time. Which brings me to a point. What if a woman is having night sweats because then she thinks it's menopause?
Yeah.
Are there chances where it could actually be lymphoma?
Yes, and that's where your family doctor will come into play and really look at your symptoms and say, okay, these night sweats is from your menopause, and hold on a second, you got the night sweats, plus you're having the fevers, plus you're having the weight loss. We got to start adding these things together, and hey, we maybe need to do a CAT scan of your body to see what's going on.
All right.
And that's where a smart family doctor comes into play to help distinguish what are the difference between the two.
So just the importance of that regular annual physical and just being aware of what your own body is doing.
Absolutely.
All right. Dr. Shakir, thanks for coming in
Thank
today.
you
We
for
love
having me.
having you on this show,
Thanks.
and thank you for watching. We'll see you next time.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255.
Rediscover Paris.
Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center.